Okay, and next I want to introduce Dr. Kat Woolley to speak with us about evaluation of spin bias in randomized controlled trials and clinical trials of mesenchymal stem cells for the treatment of knee osteoarthritis.
All right, thanks for having me. I'm Kat, I'm one of the third-year residents. All right, and I have no relevant disclosures. So you may have heard that MSCs can treat or even cure osteoarthritis. MSCs, or mesenchymal stromal cells, are multipotent cells which can differentiate into various types of mesodermal cells, including osteocytes and chondrocytes. This has led to a hype surrounding stem cell research, with many claims that are not necessarily backed by science. The media also retains a highly optimistic coverage and timeline for stem cell therapies, leading to unrealistic expectations. And many MSC trials are at risk of bias, with limited numbers of patients, inconsistent randomization and blinding, lack of controls, are often funded by the company itself, as in the case with Regenx here, and other confounding factors, including spin bias. The AAOS has included other orthobiologics, such as PRP, in their treatment guidelines for knee arthritis, but has not commented on MSCs. Spin bias has also already been investigated in other orthobiologics. So given the hype and lack of literature surrounding MSCs, we decided to focus on MSCs instead of other orthobiologics with this study. What is spin bias? Spin bias is the intentional or unintentional misrepresentation or misinterpretation of results to appear more favorable than the findings justify. So running for your life or running can be good for you. All right. In this study, we aim to characterize the presence of spin bias in clinical trials of MSCs for knee arthritis. The secondary intent was to analyze any study characteristics and its association with spin. We hypothesize that there will be spin in about 50% of trials and will be associated with lower impact journals and those with financial disclosures. In order to do this, we first performed PubMed and M-based searches for MSCs for the treatment of primary knee arthritis. All studies were uploaded to a data sheet and screened by 2 coders for inclusion criteria. The data was collected from the article and the paper. The type and level of spin was analyzed using methodology from a prior study by Boutron et al., who first described spin in randomized controlled trials. They broke it down into 3 different types of spin. Type 1 was a focus on statistically significant results. Type 2 was interpreting statistically non-significant results of primary outcomes as showing treatment equivalence or comparable effectiveness. And then type 3 was claiming or emphasizing the beneficial effect of the treatment despite statistically non-significant results. They further broke this down into high spin, moderate spin, and low spin, with high spin having no uncertainty of framing, no recommendations for future trials, no acknowledgement of non-significant primary outcomes, and recommending its clinical use. Moderate spin had some uncertainty of framing, did recommend future trials, no acknowledgement of non-significant outcomes, and then did not recommend its use. And then low spin had uncertainty of framing, recommended future trials, acknowledged non-significant outcomes, and then did not recommend its clinical use. And framing just refers to the context and language used to convey the results. No uncertainty of framing meant that the authors conveyed the message that the results led to their conclusion without acknowledging any other possibilities or flaws. After an initial search, 55 manuscripts were ultimately included. Spin was found in 81.8% of papers, with 14.5 having high, 25.5 moderate, and 40% low. Only 18.2 of the manuscripts did not have spin. We found that type 1, emphasizing statistically significant results, was the most common, followed by type 3, claiming treatment benefits despite non-significant results, and then finally type 2, the least common, interpreting non-significant primary results as treatment effectiveness. Adipose-derived MSCs were associated with a higher frequency and level of spin compared to other sources. Spin was found less frequently in the methods section compared to others, and it had the highest frequency in the results section, though this was not significant. There was no difference in spin between orthopedic journals and non-orthopedic journals, and there was no association between spin and impact factor. Papers with financial disclosures exhibited spin in 82.5% of cases, while those without, 33.3%, and this was significant. Here's an example of type 1 spin, which is focusing on statistically significant results. Here they note that 2 patients in their treatment group of rejoin did not respond to the treatment, but conveniently, if you removed them, the results became significant. And then type 2, this is interpreting non-significant primary results as treatment equivalence or effectiveness. And here they claim that the VAS in both groups reduced over time, but was considerably higher in their treatment group. This again was not statistically significant. They also claim that MSC implantation is an easy approach for pain relief and repair of damaged cartilage compared to other approaches. And in this study, they didn't conduct any imaging or biopsies to assess the cartilage. And then in type 3, this is claiming treatment benefits despite non-significant results. This manuscript was a clinical trial of 3 patients with no statistical analysis. And here they claim that MSC transplantation seems beneficial for the joint. So SPIN has not been widely described in orthopedic randomized controlled trials, but shows similar rates to other surgical subspecialties. Prior studies that have looked at spin bias in orthopedics have found a lower rate than ours, but they only reported on the abstracts. Our study found the highest rates of spin in the results section, indicating that only reporting on the abstract may underrepresent the true levels of spin. Additionally, prior studies focused on top journals with a more narrow scope, and we looked at all studies. And then additionally, we demonstrate an association between financial ties and spin bias. Prior studies have indicated that randomized controlled trials with financial ties are more likely to recommend the experimental drug as the treatment choice. Some limitations include the small number of included trials. We don't know the effect of this limitation, but again, we reported a higher prevalence of spin than broader studies. And future studies should include larger studies with strict spin screening guidelines. So in conclusion, how can we screen for and avoid spin bias? We can read the entire manuscript, paying special attention to the primary outcomes, the statistics, and the claims made in the conclusion. We should also check for financial disclosures. And when writing papers, we should be sure to explain our results without pushing a conclusion, and we should include uncertainty of framing and be sure to recommend future trials. And how does this change things? I know for me, it's convenient to read an abstract, but I think this pushes me to read the full paper for sure. And we should have more skepticism when papers do not use uncertainty of framing and are industry funded. And then finally, journals should publish negative or null results. We do think that there is a bias amongst research to have significant results. And if journals have a special column for negative or null results, which are arguably just important as positive results, this may kind of lower the pressure to induce bias and have positive results. And I'd like to say thank you to Drs. Feely, Master, and Milan. And here are my references.
Great. Thank you so much, Dr. Woolley. I think we'll start with taking any questions from our visiting professors.
Drew, that's really interesting. Do your pre-visit questionnaires end up in, or y'all, what's your EMR?
We use Epic.
Yeah. So one of the problems we're having, and I was telling Ben, we're actually looking to get rid of all of our pre-visit questionnaires because every clinic, every specialty has a different one at Vanderbilt, and it's not ending up in Epic, and the patients feel like they're getting the same questions, multiple clinics, So how are you using these visit questions beyond predicting how quickly to get them in?
Yeah, so we actually use them clinically, and they're sent to the patient electronically ahead of time, and through MyChart they can complete them, and then they are pulled directly into our note. And so we have that, what happened, why are you here, what do you like to do, what are your goals, what are your questions? And the data that we're collecting, it's really for clinical use only. And then we just thought maybe we can take a look at this and see if this could be useful before we even meet them. But that's like most of our HPI is built off of just the data that they're inputting.
Yeah, that's interesting because part of the reason we're getting rid of them is because we find that you just go in the room and sit down and ask the exact same questions of the patient, and the patient's like, But if you're using it as a way to then auto build the note, that's interesting.
Yeah, thanks.
Dr. Woolley, fabulous paper that really was enlightening. To your knowledge, has spin bias been applied to other journals specifically? Because I think what you did really outlined and highlighted how obscure some of the real data is, and the fact that journals are skewed to getting a significant result. And I think there's merit in doing a study with no significant results as well. So do you think going forward there'll be an emphasis on spin bias in addition to telling us what level of evidence it is?
Yes, thank you. Spin bias it's kind of a newer thing, and a lot more publications are coming out on it. I think orthopedics, it's just starting to be investigated, but it has been previously described in other surgical subspecialties and other non-surgical subspecialties in their associated journals. So I think as we bring more light to it, hopefully there are kind of changes in the way we present our papers and our findings to help limit that.
Great. And I just have one more question actually for Dr. Lansdowne. So it does seem like for sports that this language analysis seems to work really well, right? Like pop or swelling, something like that. But I'm just wondering, have you thought about, say, extrapolating this language analysis to maybe other subspecialties like spine or arthroplasty, where those patients aren't having necessarily an acute injury, and trying to figure out, which one of those patients might be more likely to need surgery within 3 to 6 months?
Yes, definitely. I think it's a great point. And we started with sports just to start there, but I think we can expand to other clinical services. And even, in the arthroplasty direction, it may just be matching, like, are you really ready for a joint replacement? Should you be speaking to the surgeon now, or an APP? Like, are you in that pre-contemplative phase? But I think there's other directions as well. And then we're starting to look at likelihood of undergoing advanced imaging, shortly after the visit, or having another procedure. So I think a great direction would be if we say, hey, there's a 90% chance that you need an MRI, and look, the slot's held this afternoon, we'll see you, examine you, and then if that's true, like, you're downstairs and getting a scan right after. But I think we could really expedite that decision-making, or the next steps, rather than saying, hey, all your information suggests this is the direction we're going, but we'll meet you first, 2 weeks later we'll schedule it, then we'll see you again. But we could have this much more streamlined by using this type of information.
Right. And for example, in sports, we do ask, hey, what conservative treatment have you tried, right? So if it's somebody that, say, with an arthroplasty patient, they've already tried a brace, an injection, physical therapy, they might be more likely. Dr. Wistrak, you have a question?
Yeah, thank you. All of those talks are great. I actually have a couple of questions and a comment. Drew, the contact center is coming.
Yes.
So, just for those of you that don't know, UCSF is switching to one point of contact. And so all of us have to kind of change how we've been triaging patients to a centralized unit. And there's a lot of algorithms going into this process. It's about a 8 to 9 month process to get your practice into the contact center. So this would actually be a really great opportunity. And have you talked to anyone at the contact center about use of AI in this process and what might work for sports?
Yeah, thanks. And I think that's a great point. We have not spoken to anybody, but I could see that being the direction, because I think as we move towards this larger model, the people who are triaging are even further removed from our clinical practice. And they may not know what our expertise is or what patients are best for which provider. So having these tools, I think, would be extremely beneficial to make that process a lot more seamless.
Yeah, I would encourage you to try to get on the ground floor of that, because it's really been a struggle at the Cancer Center. And then, Kat, I loved your presentation. And did you find... I've got to find the words, but did you find that with the high spin bias, yes, there were more conflicts? Were those studies paid for by the company? Because when I was a resident, we did a study just looking at the placebo arm of this prospective randomized zoledronic acid trial. So we were only looking at the placebo patients. It was just a natural history study, but every round of the manuscript had to get cleared by people from the pharmaceutical company. And so they actually had their hand in every part of the process, including writing the manuscript, which didn't even talk about zoledronic acid. So I can't even imagine what's happening when it is talking about their product.
Yeah, that's another really good question. And we're actually working on this with one of our reviewer comments at breaking down the financial disclosures, whether they're industry sponsored or not. And I can't remember the exact number, but I want to say about 60% were industry sponsored, and then the others were more grants. I think we need to look a little more closely and really make sure we've divided them between the two. But we're continuing to look at the results and the further breakdown of those. But I would say the majority were sponsored by the company itself.
Great, thank you. And I think we have time for one more question, and then we will take about a 10-minute break. Yes?
going to ask myself a question. So no, a question for Kat. So, isn't the job of the reviewers to weed out the spin out of papers? So if you looked at the quality of papers that they were submitting to, so I would assume that a high quality paper would weed out this spin. And the other question is, how objective is the spin determination process? Or in other words, was there spin in your paper?
Yeah, I think another really good question. Wait, I forgot the first part.
The first, quality of journals.
Yes.
Yeah.
No, I would have thought that as well, but we didn't find an association between impact factor and not. And we also looked further at orthopedics versus not, because the orthopedic journals had some pretty top tier journals, like Journal of Sports Medicine, knee, arthroscopy, and then there were other littler journals that was like regenerative molecule medicine, some very low impact journal people hadn't heard of, and there was no association, interestingly. And then the second question was, what was your second question?
How objective is determining the spin?
Yeah, our paper certainly could have had spin bias. I have tried to be so cognizant of this while writing it because that would be just very ironic, but it's very difficult, like I said, to convey a conclusion of a paper without pushing that conclusion. And so I think we tried to really rely on the statistics and say, this is what the statistics show, this is the conclusion we're drawing, but here's a reason, why it couldn't have worked. And then in terms of the objectivity, we used the prior methodology from another study that inherently is a little subjective as you read. What is if they have their how is their framing? That could be different between the two reviewers. So we had two independent reviewers and then a third reviewer that kind of spot checked things. And if there were any discrepancies, we made sure we got to a unified decision. But that is a very good point. It's maybe we need a language model to really help us objectify that.
Sure. So there's actually no break. This discussion is just a little longer than the last discussion. Do we have time for one more question, Rosie? Okay. I think Dr. Birch had a question.
Drew, I just want to ask you first. So in your questionnaires, do you ask the patient if they want to have surgery? Because my favorite is when the patient comes in and I say, yes, hey, you need surgery. And they're like, surgery? I never want surgery. And so do you ask them whether they want surgery?
We don't, but that's also where this is just purely to get us some information to get that HPI started. And that could be totally incorporated and I think would be great. And that's so often, we see the exact same thing. I'd never have surgery for this. It's like, well, great.
The sign on the door says surgeon. So,
yeah. But little tweaks like that could totally make this even better. But this is even, unstructured, not even intended for this purpose, and we're still seeing a benefit of using the information.
Right, and then the opposite to that is, well, then what do you do with all the people who still want to come and see you, but, don't want to have surgery?
Totally, and you could potentially see, do you still want to talk to that person, that expertise, or would you rather steer clear of it completely? And I think there are still beneficial discussions with patients who are not going to have surgery, and that's an important part that we play. But I think it's just that matching of expectations and desire from the patient with what we can offer, and I think when we do that better, I think people will be happier.
Great. I think we'll break there to stay on time, and Dr. Ma will do the next introduction. Thank you.